difficulty there. Hello and welcome to everyone joining us from New York City and from around the world for today's webinar. I am Kian Tajbakhsh, and as the coordinator for the Committee on Forced Migration at Columbia University, which has organized this event, I am delighted to welcome our distinguished panelists today to help us understand the ways in which the current pandemic has impacted negatively health outcomes among women, and particularly those suffering under forced migration. I would like to thank my colleague, Dr. Anandita Dasgupta, for organizing and moderating today's webinar. Dr. Dasgupta is an associate research scientist in the Social Intervention Group at Columbia University's School of Social Work. Dr. Dasgupta's work and research examines gendered inequities of health in the United States, India, Central Asia, and the Middle East. Also, Dr. Dasgupta is the director of the Aspire Center, a research initiative dedicated to understanding and improving the gendered health concerns of Syrian refugees in the Middle East. Anandita also has been an active member of the committee since its inception. Before I turn it over to Anandita to introduce the speakers more fully, I would like to say a few words about the committee. The Committee on Forced Migration is an initiative of the Columbia Global Centers, led by Professor Safwan Masri, the Executive Vice President for Global Centers and Global Development. Columbia Global Centers works within countries that host large numbers of refugees, including in cities such as Amman, Istanbul, Nairobi, and Tunis. In response to the pressing challenges posed by the pandemic and the forced migration issue, the Global Centers established the Committee on Forced Migration in 2018 to address this combined crisis. The committee brings together 50+ faculty from across Columbia's schools and affiliates who work on the issue of forced migration. This initiative is one of a number of forced migration-related activities that Global Centers supports. Others include the Columbia University Scholarship for Displaced Students, the Amman Mellon Foundation Global Centers Fellowship Program for Emerging Displaced Scholars, the New University in Exile Consortium, and a number of regionally focused forced migration-related programming hosted by our individual global centers. The goal of the committee is to maximize Columbia's ability to provide an institution-wide platform to engage, support, and share information across Columbia's community of faculty, students, and staff. It also acts to convene and bring together the world's thought leaders around global migration. Today is the 11th event in a year-long online series entitled Forced Migration in a Post-Pandemic World. The series looks at the impact of this crisis on forced migration, both current and long-term. Events in our series feature eminent Columbia and external experts and voices from the front lines. So I now would like to thank you all for joining us for this event, and I turn you over to Anandita to moderate today's webinar.
Wonderful. Thank you, Kian, and thank you everyone for joining from near and far. I also want to thank the panelists on this panel for their incredible support and taking the time to participate, as everyone on this panel is really focused on these really important issues related to gendered inequities of health and improving the health and lives of women and girls globally. So I don't take this lightly that people are giving us time to discuss. So I'm really grateful for that. As Kian mentioned, today we are going to talk about gendered inequities of health and how those intersect broadly with issues of forced migration. The plan is to talk about this globally. Our panelists are joining from all over the world, and I'll let them describe where they're calling in from as well. But just to sort of set the stage, when we talk about gendered inequities of health globally, and more broadly speaking, we're really talking about issues that are structurally based. So primarily, one of the biggest issues that we talk about in this world is gender-based violence, and how we've seen in terms of the COVID-19 pandemic, how we've described it as a shadow epidemic. We've seen increases in rates of gender-based violence across the world in many different populations. And when we think about support services that are offered and extended to survivors of gender-based violence and other gendered inequities of health, they span entire sectors, whether it's health, physical health, mental health, and the likes. And so today our panelists are going to talk not only about gender-based violence, but also how these larger issues around gendered inequities of health intersect with issues like family planning, sexual and reproductive health, and the like. And so we are getting perspectives from a number of different areas. We have somebody who's speaking from the direct services world. We have somebody who's speaking from more a UN agency perspective, from a policy perspective. We have academia as well. We are a university after all. And we have Women's Refugee Commission, which kind of, in my mind, is often a hybrid of all of these areas in particular. So that's what I'll say to get us started, because I really want us to spend as much time hearing from our incredible panelists. So I'll introduce each panelist before they speak. Just a small reminder and request. We really are looking forward to a rigorous and robust discussion at the end. So if you are interested, if you have a question, we ask that you please use the Q&A function. I know the chat is available. If you can put the questions in the Q&A box in particular, that will really help us out. And I'll remind everyone about this as we go along as well. So without further ado, I'll get us started with Lily Jacoby. She is an advisor for sexual and reproductive health and research at the Women's Refugee Commission. She works in a number of areas, including family planning and community-based disaster preparedness for sexual and reproductive health. Prior to joining the Women's Refugee Commission, Lily worked with programs in St. Louis and Chicago supporting survivors of domestic and intimate partner violence. Lily received her master's degree in human rights studies from Columbia University, so welcome back, and her bachelor's degree from Washington University in St. Louis. Thank you so much, Lily, and go ahead, please, when you're ready.
Thanks very much. Yeah, it's very nice to be participating in a Columbia event. I am going to go ahead and share my screen now. So as Anandita said, my name is Lily Jacoby. My pronouns are she, her, and I work with the Women's Refugee Commission on the Sexual and Reproductive Health Program. And I am calling in from New York City, where I am based. Can someone give me a thumbs up that everything looks good on the screen? Wonderful. Wonderful. So I'll be presenting on a body of work, a particular piece of a body of work focused on contraception in humanitarian settings that focused on the impact of COVID-19 on contraceptive service delivery in settings across the nexus. So we know that access to contraception is a human right, and we know that it saves lives, but we also know that access to contraception continues to be a gap in humanitarian settings. And so accordingly, in 2018, the Women's Refugee Commission undertook a landscaping assessment to improve knowledge on the state of contraceptive services in humanitarian settings, to assess progress and challenges to the successful implementation of contraceptive service delivery in humanitarian settings, and to identify key recommendations to accelerate access to contraception for crisis-affected populations across the nexus. And the assessment was mixed methods and included a literature review, a global survey of implementing partners, key informant interviews, and case studies in 3 humanitarian settings. However, the components of the landscaping assessment that I just described were undertaken prior to the onset of COVID-19. And obviously we knew that the pandemic was triggering significant shifts in contraceptive service delivery, accessibility, and availability across settings. So accordingly, WRC undertook a second round of key informant interviews with diverse stakeholders to document the impact of COVID-19 on contraceptive service delivery, innovations to ensure that contraceptive services remained available and accessible for women and girls in affected populations, and facilitators and barriers to contraceptive and SRH service delivery and COVID-19 preparedness and response across the nexus. So we conducted 29 key informant interviews with representatives of 1 UN agency, 3 ministries of health, 11 international NGOs, and 5 national NGOs, in humanitarian, fragile, and development settings across regions. The nature so I'll kind of go through some of the themes that we found over the course of the interviews. And so the nature of disruptions and challenges notably was highly consistent across diverse settings, including humanitarian and development settings, although the presence or impact of a disruption was really highly contextually. The most commonly cited challenges and disruptions included movement restrictions, including lockdowns, and a lack of PPE. And respondents also discussed challenges due to facilities and staff being diverted to COVID-19 treatment and response. Respondents reported that particularly in the earlier phases of the pandemic, the availability of long-acting reversible contraceptives, or LARCs, was particularly impacted due to providers potentially needing to use more PPE for insertion and the inability to provide LARCs via telemedicine. In addition to service delivery, many respondents reported that provider trainings, community sensitization activities, and even providers' ability to make it to a service delivery point was severely disrupted by movement restrictions, lockdowns, and other measures. And respondents also, it's really critical to point out, respondents also discussed challenges due to providers being quarantined or falling ill, and even dying. As we know, all healthcare providers are frontline workers, including those that deliver sexual and reproductive health services. Respondents reported that movement restrictions also had really significant impacts on the supply chain for sexual and reproductive health supplies at every level, starting from the top, from manufacturing, to getting products in country, to last mile delivery. These disruptions drove up transportation and shipping costs, so the costs of service delivery increased. Additionally, several respondents reported that there was a decreased availability of interagency reproductive health kits, the emergency kits that organizations can order from UNFPA that provide the supplies and commodities required to deliver the minimum service package for sexual and reproductive health services in a humanitarian setting. So there was decreased availability of those kits, according to respondents. Movement restrictions also reportedly impacted data collection and reporting for some, although not all respondents. And respondents did report that a lack of access to technology and internet connectivity impeded their ability to adapt data collection as they would have liked, given COVID-19 restrictions. We also explored the barriers that COVID-19 posed for communities to actually access contraceptive services and commodities. And key barriers included fear of COVID-19 and visiting facilities, movement restrictions, as well as associated increases in transportation costs for people seeking contraceptive services, which was also compounded by loss of livelihoods associated with COVID-19, which we know have been global in nature, and really no one has been spared from those economic and livelihoods impacts. Loss of livelihoods also posed a barrier in contexts where there was a cost associated with accessing contraceptive services. And also, given the impact on facilities by COVID-19, several respondents also described incidences of clients arriving to facilities only to find out that the facility was closed or had been diverted to a COVID-19 facility or was stocked out of their method of choice. Respondents also notably discussed acute concerns about adolescents being out of school and facing increased risk of GBV, including child early and forced marriage and unintended pregnancy. We next sort of got into adaptations and innovations, and it was really stunning to see the range of ingenuity and innovations and creativity that respondents described to ensure that services remained available and accessible to communities. Technology, including telemedicine, played an important role for organizations to adapt their activities and continue delivering services, but respondents really did emphasize that the feasibility and suitability of telemedicine is highly variable across settings and depends on access to technology. So really underscored that we should not, make this huge leap forward as a field without acknowledging that telemedicine does not work equally across contexts and across populations. And we have to be really mindful that we don't leave anyone behind. But frequently cited adaptations and innovations included use of calling and WhatsApp to provide counseling and follow-up, and to help clients find where they could actually access a method, reporting data electronically, including using WhatsApp, and using Zoom for provider trainings and WhatsApp groups for provider support and supportive supervision. Community-based service and information delivery also played a role in ensuring that services remained available. Although notably, of course, respondents in some settings also reported that they had stopped community-based distribution due to concerns about the spread of COVID-19. So really underscoring the extent to which disruptions and adaptations were highly contextual and very setting dependent. But some respondents did report reinforcing or establishing community-based mechanisms to deliver commodities, to share information on COVID-19 prevention and available services, and to encourage communities to continue seeking services, including contraceptive services, even amidst the pandemic. Respondents also discussed shifting towards the distribution of multi-month supplies for oral contraceptive pills, for DMPA-SC, also known as Cyanopress, subcutaneous injectable contraception, and condoms. Task shifting and task sharing, including shifting delivery of some contraceptives to pharmacies and dispensaries, and supporting the self-administration of Cyanopress. So supporting women and girls to self-inject their subcutaneous injectable contraception. Multiple respondents across settings also discussed the importance of integrating the delivery of contraceptive and SRH information and services with COVID-19 messaging and other priority health services. So for example, immunizations for children, to maximize resources and minimize communities' contact with the health system as much as possible. We also explored factors affecting contraceptive access and availability amidst COVID, including differences in disruptions and adaptations between humanitarian, fragile, and development settings, preparedness, and prioritization of contraceptive and SRH services during COVID-19 response. And in terms of differences between humanitarian, fragile, and development settings, it was really quite notable in the sense that a lot of respondents differed in their perception of the extent to which humanitarian and development actors were more or less equipped to respond to COVID-19 and ensure the continuity of services. So multiple respondents reported that they felt that humanitarian actors and humanitarian programs were more responsive and more agile for COVID-19 adaptations, with many respondents working in fragile and humanitarian settings reporting that they were used to sort of operating in these types of environments and that provided an advantage when COVID caused such an acute and such an abrupt disruption to day-to-day activities. However, some respondents conversely felt that development programs were better resourced and thus better able to absorb shocks and to institute adaptations in a sustainable and systematic way. So this divergence, we feel, was pretty reflective of the previously stated finding that the extent to which settings and programs were impacted by COVID-19 was highly variable and highly context specific. Humanitarian and development respondents reported that preparedness, and most specifically a lack of preparedness, played a role in SRH response for COVID-19, with respondents across settings largely reporting that both governments and organizations did not have health or SRH preparedness plans in place prior to the pandemic, and that this lack of preparedness sort of impeded actors' ability to respond quickly. With regards to the prioritization of contraception and other SRH services during COVID-19 response, we received mixed responses. So some respondents noted that governments in the settings where they worked included contraception and SRH services as essential services from the top of pandemic response, or were receptive to advocacy around why these services are essential and must be maintained and protected, while other respondents perceived prioritization to be really very low. Critically, at least for the purposes of this research, multiple respondents noted that even in cases where sexual and reproductive health was prioritized, within that contraception was not adequately prioritized, as many do not yet understand that providing contraception is a life-saving health service. Also notably, and this is, I think, relevant for the response or for the learning from the public health field beyond SRH, a lot of respondents reported challenges due to the very large volume of guidance documents that were generated, particularly for frontline staff. And that was really challenging to sift through and manage, particularly when staff were, already working overtime to try to adapt services and maintain service delivery. And respondents really emphasized that the expertise of frontline staff should be prioritized and respected in determining which adaptations are best suited for their environments, and that frontline staff are the experts on what will work and what will not work in their setting. Respondents also discussed coordination across stakeholders and noted that, as we know is true in humanitarian emergencies and in settings more broadly, coordination is key for successful service delivery. But they did report some challenges with shifting to virtual meetings, and that the sheer number of high priority demands and high priority issues that were facing stakeholders, particularly government partners, at the outset of the pandemic just posed a huge barrier for coordination to be routine and systematic and really effective, which I think also really underscores the importance of preparedness. So in that vein, respondents felt that coordination mechanisms that were strong and functional prior to the onset of the pandemic supported a really fast and effective response. And it was also noted that organizations leveraged existing relationships to address supplies challenges, including transportation of supplies and sharing or loaning supplies between organizations and facilities to meet need as best as they were able to do so. And existing relationships with governments and with ministries of health also supported stakeholders to successfully advocate for the prioritization of sexual and reproductive health. So really underscoring that all of that relationship building that goes on, outside of a crisis is invaluable for ensuring that the government is prioritizing health and protection services for women and girls at the onset of a crisis. And finally, respondents discussed the impact of COVID-19 on funding to ensure continuity of services. And really positively, a lot of respondents reported that donors were really highly flexible, that they were really responsive to organizations' needs and provided a high degree of flexibility to sort of pivot spending to meet the new needs to ensure service delivery, including purchasing and procuring PPE. But some respondents did report that governments had started reallocating funding away from SRH as a result of COVID-19. And several respondents did also report incidences in which donors were not able to follow through on planned funding due to the economic impacts of COVID-19. And diverse respondents really expressed concerns and high levels of uncertainty about what the funding environment will look like for sexual and reproductive health and protection in humanitarian fundraising in the years forward as a result of COVID-19. And I want to do a quick time check. So I'll move pretty quickly through lessons learned, but two big pieces that came out was that COVID-19 has underscored the importance of and revealed gaps in preparedness at every level across the humanitarian development nexus. And development actors have a key role to play in preparedness, but many may still not perceive preparedness to be part of their remit. And localization. So INGO respondents expressed that successful remote work and collaboration has reinforced the importance and feasibility of shifting resources closer to the field, that the design and evaluation of programming should incorporate preparedness and system strengthening activities to build resilience, and that successfully operationalizing localization will depend on donor prioritization and investing accordingly. So as I think we've all seen, COVID-19 has sort of coincided with a huge shift or a huge push to recognize the importance of localization and underscore efforts to move in that direction. Respondents were really clear that for that to be successful, for that to go beyond lip service, donor priorities have to shift and funding flows really do have to shift. And we all have a role to play in advocacy to ensure that that happens. And so I'd close with a quick quote from one of our respondents. He said, "This is something that we overlook as implementing partners or international organizations. We think that the first response to a humanitarian crisis is what we provide, what we bring. No, When people are fleeing, when people have been displaced, the first response is not coming from international organizations, not even from the government. The first response is coming from local communities, coming from local organizations. And so you can learn more here, and I can pop the link in the chat. And thanks very much. And I'm sure I've gone over time, so I'll hop off now.
You're fine. Thank you so much, Lily. That was a great way to get us started. I think, yeah, this is a great way to set the landscape for what the other panelists will talk about, and I think set us up for a really robust discussion as well. So I want to also just remind everybody to please use the Q&A to ask any questions. And so you'll hear this as a broken record as I'll continue to remind you. Okay, so our next speaker, Lily, do you mind to stop sharing your screen for a minute, please? That Shaden can? Great, so I want to introduce Shaden Khalif. She's an international expert in humanitarian and development affairs in the United Nations and an advocate for human dignity and women's empowerment. She is currently the Senior Policy Advisor for the Middle East and North Africa at the United Nations High Commissioner for Refugees, UNHCR, where she leads regional policy analysis and design. She has pioneered regional partnerships with civil society, academia, the private sector, artists, and cultural influencers through the MENA Civil Society Network for Displacement. Her expertise includes human rights law, peace building, gender policy, refugee women and child protection, advocacy and communications, multi-stakeholder coordination, the prevention of violent extremism, and the Sustainable Development Goals. Shaden has lectured at the Department of Law and at the Center for Migration and Refugee Studies in the School of Global Affairs and Public Policy of the American University in Cairo, and at the Center for Strategic Studies at the University of Jordan. She's also been a fellow at the Graduate Institute of International and Developmental Studies in Geneva. She continues to bridge academic research with practitioner know-how for inclusive and sustainable public policy. Shaden is among 100 AUC alumni of the century, as well as a Women of Egypt hero, and was selected among 365 inspiring Arab women by Women in Business Arabia. And she is a great colleague of ours as well, and it is such a pleasure to have her engage with us in this discussion. We are so lucky to have you. So please, Shaden, when you are ready, please go ahead.
Thank you so much, Anandita, for that very kind introduction. It really is a pleasure for me to be with all of you today. And I really do appreciate the work that the Columbia Global Centers do. They do really bring together practitioners and academics, and they do advance the needle on some of the very tricky issues that we're all trying to grapple with. So thank you very much for your leadership also on these important issues. I will be speaking to you about the situation in the Middle East and North Africa region and trying to collectively understand a little bit the impact of COVID in general, and more specifically, of course, zooming in on the situation of refugee women and the host community populations. But I also just want to, before I begin, very much echo a point that was just made by Lily, her last point actually about the role of local communities and organizations in being the frontliners and responding, because that is very much what we found also in one of the things that we have been working on quite significantly over the past few years, is really strengthening this engagement at the level of civil society and seeing how we can partner better with actors on the ground who are, as you mentioned, there before big international organizations arrive, and in many cases after they leave also. So thank you very much for that point, and I'll talk a little bit more about what we're doing in that space in a minute. But so perhaps what I can do now is try to get us a little bit in the mood of what it's like in the region at the moment. So the situation is, of course, quite volatile. I think it's safe to say, with conflicts unfortunately ongoing still in many parts of the region, and the devastating impact of those conflicts continues to be felt throughout and beyond, both at the economic, demographic, political, social, all levels possible. I think there is no doubt in anyone's mind that any gains that had been acquired over the past decades have most certainly been reversed, even before COVID. And now post-COVID, of course, we see a great deal of deterioration in the levels of poverty, in people's access to services, and overall in terms of well-being and health, for sure. So this makes for a very complicated situation for refugees and displaced persons and communities and host communities, who are, of course, bearing the biggest responsibility for the situation as it currently stands. We know that approximately, I mean, I'm sure many of you are aware, I mean, to say that there are approximately 80 million displaced people around the world, and 40% of those are in the Middle East and North Africa region. So that's quite a large proportion for a region that doesn't, that is already struggling with a number of issues, and of course the conflicts that are ongoing. So I think it's also important to note that the region has about a 70% population. About 70% of the population of the region is considered to be in the youth category, so that is an incredibly high number, and it also points to the needs of the populations of the region for education and for health to be prioritized. And we know that these are, of course, some of the, or two of the sectors that have been devastated by the COVID-19 pandemic, and the impact has been felt quite severely by refugees in these two particular sectors. And we also know that despite the ongoing generous contributions of donors and supporters of UNHCR's work in the region, there is a fatigue that has set in after many, many years of conflict and continued humanitarian assistance, which also, coming back to the point that Lily was making earlier, has increasingly been a priority for us to think about longer term solutions. How do we work much closer with development actors to really look at responses that are not only immediate and life-saving, but that have a longer term impact, and that include host communities and host countries also. I don't know if I should go through some of the slides perhaps, but maybe just one reference here that is important is that even before the pandemic, 60% of refugees were likely to have been working in the informal economy, which means that their livelihoods are most likely to have been the hardest hit. And this is, of course, something that we've been monitoring very closely, and monitoring also the poverty levels, which have resulted from the lockdowns and the curfews and the restrictions on movement and mobility, which we know have been prevalent throughout the region. Many of you also are aware, of course, that even prior to the pandemic, it has been difficult to increase women's participation in the labor force in many parts of the region, and some countries in the region have some of the lowest levels globally of participation in the labor market, and that has definitely been exacerbated post-COVID, or by COVID, or the economic impact of COVID. And we've seen also to a large degree, disruption in sources of income that were linked to jobs in the service industry, for instance. And we've also seen a lot of threats and heightened fear of evictions, given the difficulty to pay rent for many refugees and refugee women and female-headed households in particular. And of course, the risk of gender-based violence has been very much on our radar, has been very much prioritized as an issue for us to look into and work on, given the fact that we had noted quite an increase, of course, in instances of GBV and in instances of mental health deterioration. Perhaps some additional figures here. I won't go through them all, but the presentation can also be made available later. But I think it's just interesting to note that this, of course, the risk of GBV increased globally, but in this region, where sometimes it is in many parts of many countries in the region, these are issues which are still difficult to address and talk about publicly and openly. It has not been an easy task to unpack and address and really get to the root cause of this violence. I mean, part of it is, of course, the restrictive environment and the economic downturn and the reasons that may be familiar from other parts of the world. But in addition to that, there has been a layer of additional, let's say, cultural and historic discrimination against women that has perhaps played itself out much more prominently during the pandemic. There are, however, some good examples of how agencies, UNHCR and other partner organizations and entities on the ground have been trying to address this, and I'll get to that in a moment. So we have, for instance, as I was just saying, some examples here of some prevention measures that some of our partners have been trying to undertake. And this is including really sharing a lot more information and raising awareness about legal and medical services which are provided and which women, refugee women in particular, should have access to. And we've really been relying on local networks of women, whether as volunteers or as individuals who can come together and support this awareness raising. And that was mainly in places like Jordan. In Egypt, for instance, we also had a good collaboration with UNFPA, where cash was provided, cash assistance was provided in order to support those who either were at risk of GBV or who had experienced GBV, in order to also support a holistic response. So in many instances, what we felt is that it's important for the response to the situation to include both the health component as well as the economic component, as well as the social component. So this has been also an important angle for us to address. And we can see here a couple of other examples from Iraq and even in Syria. Despite, of course, the very complex situation there, we have tried to reach out to as many of the population groups there as possible, to also disseminate awareness and information about GBV services that are available there. Now, maybe I can step back a little bit to think, to share with you some of the policy considerations that we have been working with over the past, working on over the past year. And this is the fact that in many places across the region, access to health services was difficult even before the pandemic, given the fact that in places like Yemen or in Syria, the conflict has already devastated many parts of the health sector. So clinics, hospitals, etc., are either in places that are difficult to reach, or they have been affected physically and hit either by strikes or otherwise. So that is an issue to be taken into consideration for sure. Another policy consideration that we have been trying to address is the extent to which refugee women themselves and the forcibly displaced can be a part of the response, design, and reflection and evaluation. And this is something that we always try to enhance in our operations, is the refugee voice in planning and design, and not just in being a beneficiary or being a recipient of aid, but really being an agent of change themselves. And another important policy consideration has been the fact that, I think I mentioned this earlier, so access to justice in general, access to safe legal assistance continues to remain somewhat of a challenge. And that is something that we continue to address with our partners on the ground, and of course with the cooperation of the host communities and governments. So what I'd like to maybe also highlight here is the fact that many of you may be aware that a couple of years ago, the Global Compact on Refugees was adopted by 193 member states of the United Nations. And this was a groundbreaking new blueprint for how the world should deal with forcible displacement in general. And it's important to note that the approach of the Global Compact on Refugees really is based on two main tenets, and those are solidarity and increased responsibility sharing. So the principles that I mean, we have been calling for years, and that are very much part of our main protection considerations and appeals, but really enshrining those in the Global Compact as pillars of refugee protection, given the fact that 85% of the world's refugees are hosted in the developing world, and that poses a very heavy responsibility on countries that are already struggling with many economic challenges. So what we have tried to do is also raise awareness about this throughout the region and highlight the fact that we really need to respond with a whole of society approach. So it's no longer, it can no longer be UN agencies or governments alone, or any other entity on its own. It really has to be a whole of society response to addressing the impact of displacement. And now even much more so given the impact of COVID and the fact that we have now really realized, I think it has really sunk in now, the fact that no one is safe until everyone is safe. I know we've heard that phrase many times over the course of the year, and leaving no one behind. And I know these are maybe statements that we've really used often over the past year, but their meaning really has kicked in, I think, but in a way that perhaps it has never before. And this is really due to the fact that the virus does not discriminate, it does not distinguish, it is not prevented from crossing any border. So it really highlights the fact that we do need to come together as an international community, that we have to work with the multilateral system and strengthen it in order to respond, and that there has to be an approach that is inclusive and that is also ensuring that refugees are part of the response plans. So, and maybe I'll move now to the vaccination component of the situation and what we have been working on. So we now know that 16 out of the 19 countries where we work in the region have confirmed that refugees would be included in their national vaccination plan. So this is quite important and quite significant. And I think it speaks to this realization that I was just mentioning about the fact that inclusive policy frameworks are the way forward. We really have to be working collectively and ensuring that the needle is advanced on these issues, given the fact that the conflicts in the region are protracted. There are no immediate solutions that we can look to, unfortunately, whether they would be returned to countries of origin, given that the conflicts are ongoing. Resettlement has unfortunately been very much reduced over the past few years, and that leaves us with local integration, which is not an option in this region. So unfortunately, what we have to continue working towards are solutions that allow refugees to live a dignified life, and refugee women to continue to be protected and safe, and to thrive and to contribute to their communities while they are here, until we can find political solutions. But linking back to the point about the humanitarian and development world, the role here of women, I think, is very important, of refugee women, in linking the role that they play in sustaining their families and in continuing to contribute to the economies and communities where they are, with the longer term well-being and prosperity of the communities they are in. So linking that also to what role we have to support those communities, the host communities, with infrastructure support, with budget support to the governments, with other technical assistance to the municipalities. We're working a lot more with municipalities and potentially collaborating with the World Bank on some of these issues to bridge this gap really much more concretely and impactfully on the ground. Let me see. Yes, so some examples here perhaps that we can highlight of how we're engaging the private sector also to be a partner in this, because it really is important, and also in line with the whole of society point that I was trying to make earlier, the fact that everyone has a role to play, and I think this was also highlighted by Lily, the fact that the private sector has a critical responsibility here to step in and to support the sustainable engagement of businesses, small businesses, bigger corporations, etc., in enhancing social cohesion between refugee communities and host populations. And we found here that success stories that involve refugee women often have a great deal of impact, and they are positive entry points to this longer term cohesion that we're trying to achieve and support. So we have examples here that you can see. We also have a successful example of IKEA, for instance, working with Syrian refugee women in Jordan and supporting their production of handicrafts and products during the peak of COVID, which was a risk at some point, but I think we found that it was quite a successful endeavor, and it was done through a private sector partnership between IKEA, a big international actor, of course, and the Jordan River Foundation, which is a national civil society entity in Amman. And overall, encouraging this involvement in the humanitarian space by private actors, I think, has found quite a large degree of success, and involving refugee women in entrepreneurship projects, advancing their skills and mentorship in setting up their own businesses. And this is a space that we would like to continue to expand and to support. So I think perhaps I can end here. If you allow me, Anandita, because I think it would be interesting also to hear the questions from the participants and from the panelists. But just maybe what I'd really like to end on is the fact that we really do see that investing in the well-being, the mental and economic well-being of refugee women is the way forward, and it is really the pillar for looking at a future which is inclusive and sustainable for their families and their communities. Thank you very much.
Thank you, Shaden. You covered many, many different topics there, and I think there are a lot of parallels even with Lily's presentation already. So I agree, I'm really looking forward to the discussion as well. So I will move right along to my dear colleague, Dr. Gulin Samari. Dr. Samari is an assistant professor and population health demographer at Columbia University's Mailman School of Public Health. Dr. Samari's innovative and really meaningful research considers how racism, gender inequities, and xenophobia and migration-based inequities shape population health domestically and globally, with a particular focus on communities in or from the Middle East and North Africa. Dr. Samari was the first to draw attention to the racialization of religious minorities and Islamophobia as a public health issue. No small feat and of great importance. Her research remains focused on understanding and alleviating intersectional structural determinants of health for immigrant communities, particularly Muslim and Middle Eastern origin groups. Dr. Samari earned a PhD in public health, an MPH in community health sciences, and an MA in Islamic studies from the University of California, Los Angeles. And I will just say, as I read everybody's bios, I really feel like they don't even do the panelists justice. So I really hope everyone will take a look at these panelists' bios online, and we'll make sure to stick some more resources online so everyone can learn more. Dr. Samari, all yours.
Thank you for the kind introduction. Just getting set up, there we go. So thank you also to the Columbia Global Centers and the Committee of Forced Migration and Dr. Dasgupta for organizing this panel. It's a pleasure to be with you all today. I'm going to take a step back and sort of frame why this is a convergence of sort of two different crises, one that's really based in gender and then one that's based in the pandemic, particularly within humanitarian settings. So we know that the pandemic has really widened gender and economic inequalities. We have seen women lose their livelihoods faster because they're exposed to hard-hit economic sectors. We know that millions upon millions of women work in the informal economy, and their income fell about 60% during the first month of the pandemic. We also know that 80% of domestic workers tend to be women, and 72% of domestic workers lost their jobs as a result of COVID-19. But it's important to point out that women face the other sort of knockoff effects of the pandemic, and the impacts are not just economic. So access to sexual and reproductive health and rights are disrupted, but also disrupted because of livelihoods disruption. There's reports of violence against women that have increased around the world that my colleagues on the panel have mentioned, and the burden of unpaid care and domestic work has really increased for women and girls. So in conjunction with that backdrop of the gender challenges related to COVID-19, we know that women and girls in humanitarian settings already experience gender-based challenges. So we have disproportionate access to or exposure to violence, disproportionate access to education and livelihoods, sexual and reproductive health care, sometimes not being prioritized and needing to be elevated. So you see a lot of disparities in that space, as well as maternal and child health, again, added caregiving burdens, shifting gender norms, and things like proper shelter. So in humanitarian settings, female-headed households are nearly 30% more likely to have inadequate shelter than male-headed households. And in these contexts, women, about 70% of women experience gender-based violence compared to 35% worldwide. Additionally, in the maternal and child health space, you have 60% of preventable maternal mortality that takes place in settings of conflict, displacement, and natural disaster. So it's also important to point out that the gendered implications of the COVID-19 health emergency were recognized by humanitarian actors early on from the onset of the COVID-19 response. And so gender analysis and implications have been highlighted in the Global Humanitarian Response Plan to mitigate some of the protection and social economic impacts of COVID on women and girls. So people have been aware, but that doesn't mean that there haven't been impacts in these settings. So to summarize why migrants and refugees are more vulnerable, it's really the simultaneous aggravation of risk factors and erosion of protective factors that's amplified in humanitarian settings. So displaced women, girls, and boys face increased risk for gender and social and health inequities due to the disruption of social support networks and communities and the other factors that I've mentioned. But it's also important to note that countermeasures for COVID-19 have exacerbated some of these risk factors and reduced the access to existing prevention mechanisms. I want to point out a report that's forthcoming through a consortium led by Professor Monette Zard that's going to be discussing family violence prevention in the context of COVID-19 and forced displacement. We know that the COVID-19 crisis is generating extremely high levels of stress in home environments, and there's an increasing likelihood that women will experience intimate partner violence, and actually children will experience abuse or observe that intimate partner violence. According to the UNHCR-led Global Protection Cluster, 19 out of 21 GBV subclusters involved in humanitarian response report that GBV is occurring, and over 60% say that it's due to the COVID-19 crisis. In April of 2020, UNFPA released new projections predicting an additional 31 million cases of gender-based violence if efforts to contain the virus limited people's movements for at least 6 months, which we observed to see in many settings around the world. And for every 3 months of that the lockdowns were to continue, an additional 15 million cases were expected. They also predicted 13 million additional child marriages in the next decade due to COVID-19 disruptions. So these additional burdens from COVID-19 are disproportionately also felt by women and girls in humanitarian contexts. So some evidence specific to humanitarian contexts that we've observed around the world include 12% of Syrian refugees reporting an increase in intimate partner violence and a 29% increase in violence against children. UN Women conducted an assessment with vulnerable women in Jordan, which included Syrian refugees, and 62% of respondents reported an increase in risk of emotional and physical violence. During COVID, it's important to point out that underreporting has been exacerbated, especially in displacement contexts. So the International Rescue Committee reported a 50% decrease in GBV reports in Cox's Bazar and a 30% decrease in Tanzania in the early months of the pandemic. And then in refugee hosting communities like Greece and Lebanon, discriminatory movement restrictions have actually been placed on refugees, which makes it difficult for women to leave the household and report cases or seek medical and legal services. We also see that the economic struggles really intersect with the gendered health experiences. And so the financial instability and struggles have increased stress that actually contribute to family violence. The suspension of things like public transport makes it difficult for women in humanitarian contexts to access shelters or support provided by NGOs. And it's important to not overlook internally displaced populations. And you see that in a lot of these contexts, there's limited internet access, which perpetuates the lack of available information. It also limits access to humanitarian aid, which is known to decrease access to maternal and reproductive health care. The emphasis and the shift towards use of technology leaves out a lot of women in humanitarian contexts because there's limited private access to phones and technology to be able to access services remotely or contact hotlines. If you're in a position of confinement with your abuser, it's often difficult to reach out and get help. There's also an important age and life course dimension that should not be overlooked, which is basically that adolescent girls in humanitarian settings have really noted disruptions to their privacy, lack of access to digital environments, and increased tensions within the household. So it's created severe disruptions to their education. We did a 5-country study of COVID-19 and gender-based violence and sexual reproductive health and rights service provision. This study was really aimed to look at the extent to which the availability of GBV and SRHR services and programs are explicitly part of government's COVID-19 strategies. We looked at funding, we looked at programs and service delivery, and the study really did take a mixed methods approach where there was a desk review involved, a survey that was distributed electronically, and in-country consultants who interviewed service providers, program managers, and donors. Between about 20 to 35 individuals were interviewed in each of the countries. And I'm going to focus on the findings from Colombia because of the Venezuelan migrant situation. But the findings from all of the countries really did emphasize that the most vulnerable groups in all settings, including the United States, were migrants, asylum seekers, and refugees. Some of the overarching themes that emerged were, a lack of preparedness and stress on an already weak system, disruption of services and confusion in all the settings around what is essential, and further reduced access due to restrictions and fear of COVID-19 and confusion around the availability of services. In Colombia, we observed, the timeline is there for you on the screen, but we observed a 33% increase in the demand for GBV-related support services during the period of strict confinement. Most of these cases were related to sexual violence against girls and boys and psychological and physical intimate partner violence against women. Between March and April of 2020, around 238 femicides were identified and almost 164,000 GBV-related calls were made to helplines in Latin America and the Caribbean. In Colombia specifically, staff reported an increase of nearly 80% in the frequency of calls to NGO helplines because of GBV, and a 62% increase in psychological first aid consultations related to family violence cases. Some quotes are on the screen, but I just want to point out that the situation with the Venezuelan migrants in Colombia was notably bad with regard to sexual and reproductive health. Around half the interview participants mentioned the discrimination and problems of access to sexual and reproductive health and GBV services experienced by Venezuelan migrant women. The interviewees pointed out sometimes they don't even get to complain, and that Venezuelan women have more difficulties accessing services because many of them are concerned about their legal status, so they don't seek the services. The Venezuelan migrants have also had difficulty accessing abortion, do not ask for help regarding gender-based violence because of fears of legal status. They also are not prioritizing GBV and SRHR because they are focused on access to food and financial security. The rapid response to sexual violence is very complicated for this population, and there was more later term pregnancies observed because the services for migrant women were really far away. And so there were transportation issues. So there's a lot of complex factors going on with surveying these populations in Colombia that were exacerbated really by the COVID-19 pandemic, but also leading up to that, the global gag rule, which restricted funding for abortion, from the United States. The last thing I want to point out is this commentary that we recently published, led by Professor Monette Zard in Nature Medicine about equitable vaccine access for refugee and displaced population. I think it's important to think about this within the context of a gender lens, which is that the intersectional identities that migrant women and girls face in trying to access vaccination. So as I've pointed out, women tend to face limited mobility to reach health facilities and could have difficulty reaching vaccination sites. They have limited decision-making power in their health-seeking behaviors. They have limited access to health resources, including evidence-based information on vaccine safety. And in many settings, women and gender diverse groups are also at risk of experiencing sexual harassment, exploitation, disrespect, and other forms of gender-based violence when seeking health services, including vaccination. So as we expand equitable vaccination to refugee and displaced populations, we need to be mindful of the intersections with gender-based inequities. So ongoing and future needs have really been highlighted by the other panelists and my colleagues on this panel. But inclusion of gender-based violence and sexual and reproductive health and rights services should be essential from the onset. We should not divert funding from existing programs to COVID-19 response because these programs are essential for women and girls. We need ongoing research on the impact of COVID on internally displaced women. Mental health support is critical. We need localized funding for local feminist and women's group, increased support for gender-based violence survivors. And basically the overall message is that if we change this infrastructure and we're faced with this ongoing reality and future crises, it can produce better conditions in the future. Just some brief acknowledgements, and I'll thank you all for your time.
Thank you so much, Dr. Samari. That was fantastic. I know that you have to jump off at 11:15. So if anybody has any questions, I see a few in the Q&A box, but just a gentle reminder to stick your questions in the Q&A box, especially for Dr. Samari, who I think has her work cut out for her now to respond to a few questions in the chat while our next speaker is speaking. So thank you again. And now it is my great pleasure to introduce our last speaker. Marijana Savic is the founder and director of Atina, Citizens Association for Combating Trafficking in Human Beings and all forms of gender-based violence. And I believe she's based in Serbia at the moment. The majority of Atina clients are impacted by forced migration. Atina promotes women's and children's rights within the developing social and political environment of Serbia, specifically advocating for victims of trafficking, sexual abuse, labor exploitation, discrimination, and violence. As the director, Marijana is responsible for providing overall organizational leadership, engaging with new partners and grassroots organizations, and monitoring Atina's programs. In addition to her work with Atina, Marijana has served as a consultant for international NGOs and state governments advocating for the inclusion of marginalized trafficking victims in human rights policy. Marijana received her law degree from the University of Podgorica. In 2018, she was on the Forbes list as one of the 8 women in the world most prominent fighters for the rights of refugee women. Recently, Marijana became a member of the executive board of the Global Fund for Children. So quite an extensive CV there as well. And I'm looking forward to hearing from Maja about the work on the ground that she and her incredible organization are involved with. So I'll leave it to you. Please take it away when you're ready.
Thank you for this kind and nice introduction, Anindita, and thank you for the invitation and this opportunity to a little bit introduce all the participants with Atina's work and with work to promote women's rights in Serbia. Actually, all the women, girls citizens of Serbia or refugee women and girls. So I will jump immediately and share my screen to introduce you with the context in which we work. So just a moment. Is it so welcome to Belgrade, to Serbia. It is our office here and it is a sunny day. We are working in the Serbia, but we are also working in the region, supporting women and girls. Serbia is a post-conflict society, as you know, and we had, unfortunately, experience with the exodus of a lot of people, with experience of refugee and internally displaced people. When migration crisis struck Europe in 2015, unfortunately, we had a lot of refugees and IDPs still in those collective centers as asylum centers from previous civil wars. So these civil wars torn practically Serbia and the region, and we are still somehow in transition as a society and in ongoing and continuous political and institutional crisis. So Atina was founded 18 years ago as a response to this institutional crisis and to response to this conservative, non-flexible and insufficient response to the needs of women and girls who suffered violence. And for 18 years, we are trying to develop and push for the framework that will respond to the needs of women and girls. So the beneficiaries and the women and girls that we are working with are those who are specifically survived violence, trafficking, and almost any form of exploitation. So these are those women and girls who are recognized in our country by institutions, by NGOs, by international NGOs, UNHCR, are referred to our programs. And when we started, there was a lot of foreign women who were trafficked in Serbia in post-war context. And actually, they were not recognized as refugees, but they were like running and fleeing from their home from the poverty. And poverty is totally different for men and totally different for women. And there is equation between, I have to say, with this experience of 18 years working with those women, is that there is equation between poverty and violence for women, not always for men. So this is like something that we had a lot of women from Moldova that were fleeing from not just domestic violence and not responding to their needs, and they didn't receive help, but they were like fleeing to searching for their new opportunities. And in this transit, in this road, they were trafficked. We set up the NGO and that pilot project back then in 2003 to support them. After a while, we started to develop services for Serbian citizens, because there was a number of them who were violated in different grounds. And in 2014, when migration crisis started, as you know, there was a lack of resources and there was no gender perspective in addressing this crisis. And we step in with our experience as a feminist, as a women NGO, and with our resources, and definitely started to support those women who were traveling to Serbia. So refugees and migrants are almost majority of women and girls that we are advocating for their rights and that we are supporting. They are from Syria, Iraq, Iran, Afghanistan. A lot of them are coming from African countries as well. I have to say that they are identified as, most of them are identified as someone who survived some form of violence, but many of them are forced married, ran from forced marriages from their countries of origin, but also they didn't have access to education. They just wanted to, and there was a lot of pressure in their countries, in the countries of origin. There was a lot of violence for some of them during the transiting and during the travel to Serbia. Unfortunately, there is a lot of violations within Serbia while they are residing in collective centers. So I have to say that Atina is lucky that we can do, we have services that are set and that are in revision, and that we can offer something for women and girls that suffered violence. And practically through these 18 years, we developed different services and different actions correspondent to their needs. We have accommodation, safe and alternative accommodation. We have legal assistance, psychosocial support. We even, because of the lack of economic opportunities, founded a social enterprise. We are producing bagels, and we are cooperating with private companies all around Serbia and cater. With this action, we are trying to secure some economic opportunities for refugee women and girls. And we are lucky in the way that all our programs are set to be long-term and comprehensive, and that we don't have a limitation in what we are doing. So this is like something that we can see the impact. And after 18 years of supporting those women, you can see first 5 years is hard, but when you are doing that and you're revising and you are including those women in creation and setting up the programs, then you can see the benefit of it, and you can turn back and see those strong women that when they are supported in the way they need, what they become. So, well, I try to give a context. So we are not a humanitarian organization. We are working in, sometimes in humanitarian settings, but what we saw is that there is a lack of feminist women-centered approach in the response to the needs of refugee women and girls. And that was our main goal, was to advocate, to incorporate this kind of approach in the addressing the women's needs. So still in Serbia, violence is not recognized as a priority on the agenda. And one of the things that we are doing parallelly to providing services is the pushing the issue of the violence against women to those who are decision makers. The priority of the organization is to provide timely information and to set the environment to provide timely information to the women that they need. And this is why we set up the peer support group, and we invested a lot in cultural mediation. What was needed also is to connect and maintain continuous support on the road. We have many of women and girls who are coming from Turkey, from Bulgaria, Greece, and traveling to the EU. So it was of most importance for us to map different organizations, women feminist organizations that can provide support through that network, and to have on the same rights and with the same principles as we are working, and of course addressing specific women and girls' needs, not to follow the principle that provides everyone equally. we were talking a lot about challenges, and my previous panelist practically mapped the similar things that we are encountering on the field. With the COVID, when the COVID started, we had unfortunately curfew in Serbia, and immediately with the starting of curfew, practically military entered the asylum and transit centers, and it really triggered the trauma for many of those women. Another thing is that, as some of colleagues said, many of those women who got refugee here in Serbia lost their jobs because they were employed in informal settings. We are, I have to say, we experienced increased xenophobia and hate speech, because whenever we were advocating for better protection and support to those women and girls, it triggered the hate speech and xenophobia in public arena. Delays of asylum, of the legal processes for asylum status, legal protection were present. And because of that, it limited access to the different rights from the health system and educational system. Someone mentioned the GBV, and Anita, when you introduced, you said increased numbers of GBV. All the women organization, feminist organization in Serbia that run hotlines, and Atina is one of them, noticed that there was like increased of those women who were calling hotlines and needed help, but they stayed underreported in the state statistics. And it was those statistics are not representative in the terms of what was happening in the film, because practically institutions stepped back in providing services for women and girls in Serbia, and especially for refugee women and girls. The transit, the travel, their way to the EU become more riskier. Immediately after the start of pandemic, the smugglers, of course, increased and tripled the price of the price to transit the borders. Experience of women we were talking, it was like that one border to pass. That was from Serbia to Croatia, and from Bulgaria to Serbia was $1,000, and now it is $4,000. And that also made those risk for debit bondage, the risk for survivor sex and others more present. This fragile relationship that was built during the course of these years was jeopardized, and there is like immediately when institution and institutional support stepped back, it was practically jeopardized. So I have to say that we also had a lot of unintended pregnancies, and that is something that we step in as a feminist, as a women NGO, to support those women to take care of it, even if there is like in Serbia, like free, you have a possibility on the paper to definitely control, to put it to abort, let me say. So this is like something that is the situation. What we did and what we are doing now, it is that we immediately, with the closing of camps, with those things that with the situation that we couldn't enter the camps, we set up the online counseling. The challenge of online counseling is also first trust and regaining the trust. A lot of them, many of them had experienced digital violence. So this is not the same connection as face-to-face. The another thing, what was mentioned when I was following previous panelists, is that the issue of privacy. The issue of privacy and enabling the space within the collective centers where women can feel safe. So we are advocating for that. It is not just collective and asylum centers. We also have women in our safe accommodations, but through safe houses in Serbia. We invested, and we are proud to say that we have a migrant and refugee advocacy group now. And those are the women who got asylum here or any another kind of protection, and are staying with us in Serbia and working with us. So we have a more flexible and more meaningful contact with the refugee and asylum centers. I like that we mentioned a lot the local system, and I do believe that investing in local mechanisms is crucial. And I have to say that investing and relying on the women and feminist organization and their experience in working with women is crucial. The problem and the challenge in Serbia is that there is like a lack of trust between NGOs and the government, and civil society is perceived as an enemy in non-democratic societies. So this is something that is always a challenge for us to like put all the things and challenges in front of the government and the officials and institutions. And it is something that international organization, especially UN organization, should have in mind to put it forward, and when they're in better position to negotiate that and to make pressure to the governments. We after the curfew and immediately when we had the possibility to get back to the camps, we intensify our activities there, and that is something that now this moment is ongoing. I think that we are in the few camps, and my colleagues are now in the south and in the north. And what I would like to say is that the most important thing when these pandemics collide is always and in every moment is listening to the women and know how to listen. And we all have to advocate for women's rights, believe in women and believe to women. And I will finish now and wait for the questions, but I would always bet on women and girls' agency resilience, and that is something that is the only solution we have, actually. So thank you.
Thank you so much, and that was fantastic. I know we have just a few minutes for questions. It looks like there have been a number of questions in the Q&A box that Dr. Samari answered before she had to take off. I think just to end, we can maybe end with each of the panelists answering one sort of broad global question, as well as maybe commenting on anything else that they've heard as they're going through. As the other panelists spoke, in 1 minute or two, can you each summarize sort of, as each region that you are working in or engaged with looks at the next phase of this pandemic, whether it's in Jordan, as Jordan is dealing with a huge surge in COVID cases, whether it's vaccine distribution, whether it's additional lockdown issues, whatever it is, what is one major thing, one major resource, one major solution, just one that you feel should get priority at this point? And anyone can start, whoever. It's a broad question, and I know there is not one answer, but just to continue.
I can get us started, Anandita, if you would like. I think really for us, what we are hoping to continue to work towards are inclusive and holistic policy frameworks that allow women to thrive and to contribute the best that they can to their communities and for their rights to be upheld. I think, and of course, that refugee women would be the main focus there. I think that the more I heard from the fellow panelists about looking holistically also, I think I was really glad to hear that echoed by everyone, looking at the holistic situation of refugee and displaced women's situation and how to address the various components that they are struggling with and juggling and being challenged by, and looking at how we can bring them all together to one, to address it holistically. I think that really would be our main objective.
Thank you.
Can I?
Please.
Okay. So I would prioritize inclusion of these women and girls in decision making, and also to have a more agency in the settings of collective centers and asylum centers, and also relying on the women movement and feminist organization all around the world that have so much experience that are unused, and it is a huge resource that is not used at all in the way that should be.
Thank you.
Ooh, that's a lot of pressure to follow, to follow and close out. And since I did touch a bit in closing and really heard it echoed across panelists around localization, so maybe to just give that one more plug and to link that to colleagues' sort of key takeaways, is that the resources, the expertise, the capacities that exist among women, we have to shift our funding, we have to shift power, we have to shift decision making, and get out of the way, because so many of those resources are there. And I would link that, I think, also to preparedness, and just to sort of give another plug for preparedness as one of the big solutions that we should all be walking away from this pandemic with a greater appreciation for. We know that the frequency of crises is increasing. We know that the duration of crises is increasing. We know that the number of people affected by crises is increasing all of the time. This is only going to continue as climate change exacerbates drivers of conflict, of displacement. But the pot of funding available has not been increasing in kind. And there's all sorts of work that is being done and will need to be done on how to motivate funding for humanitarian response. And that's a separate conversation, but it is more important, perhaps now than ever. It has always been important, but neglected, to ensure that aid is cost efficient. We have to do the most with what we have, and preparedness is a huge part of that. We know that preparedness is one of the most cost-efficient ways to respond to a crisis, and that it can reduce the damage caused both to infrastructure, to communities, to individuals across the board. And this is true of every sector, not just health and protection, but it is also true of health and protection. We are able to be more prepared than we are to meet women and girls and LGBTQI persons and persons with disabilities and adolescents and older persons. All of these communities that are traditionally underserved, preparedness can help us to meet their needs. They can help themselves if we give them the chance and we invest in these organizations and these individuals. And preparedness is a huge part of that. And that is true not only for humanitarian actors, it is also true of development actors. And there's a really critical need to increase investment in preparedness, to increase collaboration across the humanitarian development nexus to build preparedness. And I think COVID has forced a lot of people in a lot of countries and settings that would not have historically said that they thought that they were vulnerable to a crisis to confront the fact that they are, in fact, very vulnerable to crisis. And in a lot of cases, we did not manage it the way that we would like to think, we would have wanted to think that we would have, and preparedness is a part of that. So yeah, I think that's one of my big lessons and big takeaways, is just a big push for emergency preparedness.
Thank you for that. Yes, I think there have been also a number of commentaries. I think Dr. Smari was also involved with some of those as well, where the authors have also talked a lot about sort of lessons learned from humanitarian settings that can be applied to the COVID pandemic. I think, Lily, the point that you made that was really heartbreaking to me and also so poignant around what some of the providers said about sort of, this is what we're used to dealing with. We're used to being in resource scarce environment. We're used to sort of responding quickly and shifting as needed. And this concept, I think, that we've heard across all the presentations of sort of, in my mind at least, how do we make gendered health services as essential services, not just within the context of a humanitarian crisis or a global pandemic, but in life in general, in stable times and stable settings, right? So I think it was very interesting to hear that echoed over and over again. The other theme that I think we've heard over and over again is really very salient, is around the link between poverty and gender-based violence, and how that connection has really resulted in lots of interruptions around sexual and reproductive health needs, as well as mental health and all these other issues as well. So, I mean, it feels like we could draw a very complicated, intertwined spider web of all these issues, because they all seem to be really intersecting together as well. Unfortunately, we are out of time. So I am very sad to end this. I feel like we could have spoken for another hour at least, but it was incredible to hear from each of you about your perspectives and the work that you are all doing. I hope everyone is able to stay as safe as possible, especially as the COVID numbers increase in certain areas that many of you are in. Just a note that this webinar is being recorded, and I believe it will be posted on the Global Center's website. And maybe it will also be emailed out as well for those who are looking for it. I think that's it for now. And I want to thank everyone again, the panelists and those who are attending, the organizers as well. It's been a great pleasure. Thank you, everyone.
Thank you.